intern at Jesse Brown VA. On behalf of Northwestern University's Feinberg School of Medicine and the Jesse Brown VA Medical Center in Chicago, I'd like to welcome you all to the 2020 Health Psychology Seminar Series. We have a great lineup of health psychologists, and the seminars will occur most weeks on Wednesdays at 2:30 p.m. Central Time through December 2nd. For those attending our live presentation today, we're so glad that you could join us. If you don't mind, please type into the chat box where you're joining us from, including your program name and location, so that we can get a sense of who's tuning in. You can also type questions into the chat box during the talk, and we will relay them to our speaker at the end of their presentation. Before we get started, just please take a second to make sure that your microphone is muted. I'm honored to introduce Dr. Adrienne Williams, Director of Behavioral Science and Associate Professor of Clinical Family Medicine at the University of Illinois at Chicago College of Medicine. Dr. Williams completed her undergraduate degree at Yale University, her master's and PhD at Duke University, and her internship at the North Florida, South Georgia VA Medical Center. She completed her fellowship in health psychology/behavioral medicine at the Consortium for Advanced Psychology Training at Michigan State University. Dr. Williams specializes in behavioral medicine, sexuality and gender, and brief evaluations. Today, we're thrilled to welcome Dr. Williams to present on teaching the patient-centered pelvic exam.
Thank you very much, though. I really appreciate being able to be here and to be able to give this presentation. This might be a little bit different of a presentation than some of the other presentations that you are experiencing through this series, because part of what I am talking about today is how to teach the patient-centered pelvic exam. So instead of talking directly about my own patient care in sexuality and gender, or my role in behavioral medicine in a family medicine residency, I am really going to be focusing on how to teach physicians, because this is one of the things that a lot of health psychologists do. A lot of health psychologists are placed in a position where they are able to teach people from other disciplines, including physicians, nutritionists, social workers, physical therapists, lots of different areas. And so, especially with health psych, there is a lot of interaction with physicians, and I want to make sure that people are aware of some of the different ways of teaching specifically physicians. So I'm going to be going over a lecture that I often give, a training that I often give for physicians, and I have given this training in a lot of different residencies. I'm going to be including this in here. I'm not going to go through every single detail because most of you are not going to be actually performing pelvic exams in your actual practice. But I will be going through what it is that I teach the physicians and the teaching points of how to be a good teacher when you are teaching physicians. So the objectives in general, for today are to learn some of the key techniques for patient-centered pelvic exams, but like I said, I'm not going to go through all of them in detail, but we are going to be discussing key points for teaching physicians about physical exams. So you will be learning more about patient-centered pelvic exams yourself, because you might also need to explain this to physicians, even if this is not your area of specialization. This will also be to demonstrate the health psychologist's role in medical education, so that you can see one of the ways in which health psychologists can actually be a very strong part of medical education, and not just in an area that has to do with mental health. I'm specifically doing this on patient-centered pelvic exams because it has typically been seen as a physician or nurse practitioner only area of practice. So I do want to make sure I go over my conflicts of interest. I don't really have any conflicts of interest. I am not selling anything with this, but I do want to let you know that I am willing to give this training at other sites. And that is because a lot of times when people see this training, they realize how much the physicians at their site are not doing patient-centered pelvic exams. And I might get invited as a result to other training locations so that they can also get this training, so the physicians there can get this training. My background is that I had a specialization in sexuality. I started off working for Planned Parenthood, doing a teen advisory board in high school where I got to teach my peers about sexuality. And I would often hear complaints from friends. And then once I did get into sexuality and gender and seeing my patients, I would start hearing a lot of complaints from my patients. And that is, I was seeing a lot of patients with sexual dysfunctions, especially a lot of women with dyspareunia, which is pain during sexual contact, or vaginismus, which is an involuntary muscle contraction in the lower third of the vagina. And when my patients would have these complaints, I would notice that some physicians, when their experiences with some physicians were completely fine, but then their experiences with other physicians were not fine. So I started looking up more information on pelvic exams. I did this as a psychologist. I saw that a lot of my patients had very traumatic pelvic exams, and so I wanted to look more up about pelvic exams to see if this was an area that I could provide more teaching in for the physicians. I saw that pelvic exam was listed as a procedure with no risks, which shocked me because in the psychology literature, it had often been cited as a risk for dyspareunia, pain during sexual contact, or vaginismus. So I was very surprised to see that it had been listed as having no risks. This let me know that there was a need for this type of education, that there was a gap in people's understanding. So with this, I was able to also observe a lot of family physicians giving pelvic exams. Now, for those of you who are not familiar with what a pelvic exam is, a pelvic exam is when a person who is either a female or identifies as a woman, or could be a trans male who still has a vagina or who does have a vagina, goes to the doctor to have a vaginal exam. And usually what happens is that a speculum, which looks like this for those of you who have not seen one before, is inserted into the vagina so that the healthcare provider can look inside of the vagina, often taking swabs from inside of the vagina to make sure to test for any kind of disease processes, and sometimes we'll also insert fingers in order to determine any kind of disease processes going on with the ovaries, the uterus, or within the vagina itself. So this was the procedure that I was hearing so much about. I would hear people talk about this all the time. In fact, and it was surprising how often I would hear that people hated this. And if I knew that so many people were hating this, I knew that there was a problem here that could be addressed. So this is where I started with this. And I started by developing this training that was called Improving the Pelvic Exam, Reducing Iatrogenic Effects, Decreasing Distress, and Enhancing the Doctor-Patient Relationship. And what I did here was I paired with a family physician. And that was, I knew that as a psychologist, a lot of people would see me coming in and saying, hey, I'm going to teach you how to do your job, which is outside of my scope of practice, but I'm going to teach you how to do it. That could meet with a lot of resistance. Because I knew that could meet with a lot of resistance, I paired with a physician, Dr. Adrienne Williams. I'm not related to her, because she also had a passion for improving the patient's experience during their pelvic exams. So this way I was able to present this information alongside of a physician. And so this is one of my teaching points here, is that in the beginning, you might want to partner with a physician to start getting the message out. Now, after I did my initial trainings with this and I started to learn more about the pelvic exam myself, I did actually go through the training that medical students go through when they are learning pelvic exams. And this all gave me more information. And so one thing to keep in mind, so I've often got this gotten the question of, kind of what makes you qualified to do this. And one thing that I want to remind everybody, especially because health psych is such an interdisciplinary field, is that our license is what determines our scope of practice. So it says what it is that we are able to do with our patients. Our license, though, does not limit our knowledge. And we, as psychologists, are able to learn things the same way that every other field learns them. And once you have knowledge, you are able to disseminate that knowledge. Your license does not limit your ability to disseminate knowledge. In fact, anybody can post anything they want on the internet and disseminate knowledge that way. It is better for you to become competent in the knowledge that you wish to disseminate and have good knowledge before you decide to disseminate it. But any field in which you feel passionate about, even if it is outside of the scope of practice of psychology, is still a field where you could develop enough knowledge in which you could provide teaching in that other field. Now, after I paired with Dr. Williams, eventually I had done this training enough that I was able to then go off on my own and do it myself. So I've been doing it by myself for probably 7 or 8 years now. So at this point, I have enough experience of doing it by myself that people, and my name has gotten out there enough with doing this training that people don't question me about doing this training anymore as a psychologist. So then I present the objectives to them, which for this would be learning the potential adverse outcomes, discussing techniques to improve the exams, and develop a strategy for implementing the techniques into practice and training. So one thing I want you to see here is that my objectives here are not the same as if I was teaching psychologists. Often when we're teaching psychologists, we start with theory. We start with, this is how we want you to think about things. When you're teaching physicians, you want to start with just, why is this important for your practice? Not how do you think about it, but why is this important to your practice? What are the techniques? What are you going to actually do? And how are you going to implement this into your practice? So it is much more practical and less cognitive. So my teaching point here is, don't start with theory when you are teaching physicians. Start with something that is directly related to their practice. Then I move on to a case example. So Katiana is actually a patient that I did see. That is not her real name. And this was a patient that I saw who was around age 36 when she was referred to me. She was referred with chronic vaginismus. She was, as I said, I think she was 36. When she was a child, her goal was to grow up, get married, have 6 children. When she was around age 14, she presented to the emergency room with abdominal pain. And at that time, one of the main things that you did in the emergency room when you had an abdominal pain was to do a pelvic exam, to look in the vagina to see if anything there was causing the pain. She did not understand what was going on. She did not fully, as a result of that, she was not able to fully consent to what was going on, and did not feel, and the exam ended up being very painful for her. After that, she developed a full fear of going to the doctor and having a speculum exam. So she avoided going to the doctor for years and years. She did want to become pregnant. As I said, she wanted to have 6 children, but at this time I was seeing her, she had been married for 10 years, and she had never been able to achieve intercourse with her husband because her vagina was too painful. So she got referred to me for both of these issues. I was able to diagnose her with both vaginismus, which was the vaginal pain she was experiencing, and also with actual PTSD. She actually met full criteria for PTSD from the non-consensual speculum exam that she experienced, that she felt that she did not have any control over. So this is an example of a patient that a lot of physicians might have seen, right? A patient who just comes, who comes to the doctor for something, who doesn't want to have a pelvic exam. That sounds like a lot of people. And that they might not have even known that that their behavior, that they're providing this pelvic exam even created these iatrogenic effects in this patient. So their behavior as physicians had actually created harm in the patient. It created a diagnosable condition because of what they did, and they weren't aware of it. So it's a little bit scary for people to hear that their behaviors, that their practice might have actually harmed a patient without their knowledge. But this pulls people's attention into how you're going to make sure that they don't do this type of thing. So the case example can be very powerful in that way. Make sure that you are using real cases. And this was a case that I actually saw. This was not the most extreme case that I saw, because you also don't want to turn people off where they're going to think, well, that's never going to happen. That's not the typical patient that I see. This was a patient who was just a typical patient that I saw for vaginismus, and I was able to say, yeah, like some of you in this clinic probably saw that patient and did not know that this is what happened to her. Just a quick update on this patient. We did successfully treat the PTSD and vaginismus, and she was able to become pregnant after that treatment. Then we go over what some of the iatrogenic effects actually are. So we do have pain, discomfort, embarrassment, powerlessness. These I tend to focus on for just a little bit because a lot of times physicians don't consider these to be very important, even though we as psychologists would probably consider these to be very important. But we do talk more about the strained doctor-patient relationship, re-traumatization, and then the actual diagnosable medical conditions, which would be vaginismus, dyspareunia, or apreunia. Apreunia is the complete inability to have sexual contact, and the avoidance of future medical exams. And we really kind of focus on this. When patients are not coming to the doctor because they had such a bad experience with one thing, they're not getting a lot of their other medical care. And so there's been studies that have found that patients who have a bad pelvic exam don't come back for other types of care. And so this is also a way to make sure that those other types of care are also engaged in. It was really, I just have to say, it was really easy for me to find these little cartoons about how bad pelvic exams were. And actually, even yesterday, I was just on TikTok and somebody was just making jokes on TikTok. Yes, I was on TikTok. That's an admission. And somebody was making, like, there were just some jokes up there about, like, how bad going to a pelvic exam was. And that was also just really interesting about how prevalent this is in our culture, that women and other people with vaginas would be feeling so harmed by these procedures, but things were not being done in order to make them a better experience for the patient. The next thing I go through is physician-related factors that might contribute to this. I actually don't spend a whole lot of time on this slide. This is more just for people to know, for them to be able to check themselves, and for them to be able to contact me later if they need any help with any of these things. So I might just say that that a physician might have their own discomfort with discussing sexuality. They might have a limited time to establish rapport. They might have some cultural factors or religious factors that make doing the pelvic exam or talking to their patients about sexuality uncomfortable for them, and that if those are things that they think would be a barrier, that could be true for them and a barrier to providing good care for their patient, I am happy to consult with them to talk about how to address those factors. But other things is that physicians often have myths and attitudes, and here I actually go through some of the myths. And part of the reason why I do this is because a lot of the physicians will then pay more attention because they'll realize, hey, I believed some of those myths. So we'll talk about things like patient pelvic exams are often painful, and that's kind of normal. That is actually not normal. Patient pelvic exams are painful in two situations and two situations only. Either the provider is doing something wrong, or it is a positive finding, that is, there is something wrong with the woman and something does need to be addressed. There is some condition going on that needs to be addressed. So if it is painful, one of those two things is true. And then I might open it up, like, have you had any patients say that their pelvic exam was painful? Did you investigate those two factors? Or did you just try to get it over with quickly? And if you tried to get it over with quickly, you're missing those two factors. With the number of people that are on this call today, my guess is that at least some of you, I mean, just statistically, at least some of you will have had a painful pelvic exam. And so I also want you to know that that is not normal, that if it is painful, then that means either something is going on or that your provider was doing something wrong. Other myths would be things like people with a BMI over 35 are going to need the extra large speculum, and it's just going to be painful because of the person's obesity. That is also not true. Other myths could be people who have had a lot of sexual partners will not have any pain or discomfort during the speculum exam. Also not true. So we go through a lot of those. And then we also want to acknowledge the time pressures, because this is the part that actually makes a lot of the physicians not do a good job on their pelvic exam, because they are pressured by time themselves, and so they are not taking the time that is needed to avoid the iatrogenic effects. So with that, we make sure that we are talking about that the risks and benefits. The risks of not taking the time that's needed for a good speculum exam far outweigh the benefits of doing it quickly to get it over with for your schedule for that day. Then we start moving directly into techniques. So the first technique is to identify the patients at risk. So we have a number of patients that might be at risk here. Patients who have, so you would just, when you're talking to the patient, so you're in the room with the patient still has their clothes on, and you are talking to them about their medical history. You would ask them about their history of sexual abuse and assault. And then we actually go through the appropriate way of asking about a history of sexual abuse and assault. So for example, you don't ask, have you ever been sexually abused or have you ever been raped? And the reason for that is that most patients who have experienced the legal definition of rape, in fact, 75%, one study found 75% of women who had experienced the legal definition of rape did not identify what they went through as rape. And we have found this more and more across the years, especially as the portrayal of sexual assault in the media has become more and more violent. So, which then eliminates the other types of sexual assault that are nonviolent from people's general vocabulary. So we have very specific wording here, and there will be a handout at the end that you'll see that we do give to all the physicians that has the wording for the screening. And so the specific wording here is, has anybody ever touched you in a way that made you feel uncomfortable, or had you do something sexual when you didn't want to? It is not forced to do something sexual when you didn't want to. It is had you do something sexual, because there's lots of ways that somebody can have you do something sexual when you don't want to without the application of force. If the person had any painful speculum exams in the past, they are at high risk. If they have difficulty with tampon use, painful sexual contact, if the person is sexually inexperienced. This is a place where I usually pause. If a person's sexually inexperienced, you need to be asking, should you be doing this speculum exam to begin with? A lot of times people will do speculum exams for reasons that don't need to be done, like you need to have a pap smear before I will give you your birth control. That is not a thing. That is not, you are not required to undergo a screening test for cervical cancer before you are allowed to not get pregnant. Those are separate things, and physicians are actually not allowed to hold one hostage to the other. So if that is happening, that is actually a cause for concern in terms of ethically not providing medical care unless you are submitting to a procedure that you may or may not consent to without that pressure. If it is the first speculum exam, that is also putting the patient at risk, and if the patient has any inaccurate beliefs about their body or anatomy. So a couple of teaching points here. One is that I start here because I use stats. So you'll notice here that when I talked about the history of sexual abuse and assault, I used an actual statistic. this helps to get buy-in from the physicians. The other thing that I usually include here is to make sure to use gender-neutral language. So this is painful sexual contact. It is not painful sexual intercourse or anything like that. And you can also use jokes or things like that here. So for the part where I say, like, if the person is sexually inexperienced, you need to figure out whether or not you actually need to do a speculum exam on this day. And if you identify any of these risks, you might actually need to delay that speculum exam for another day, to another day. And that is because speculum exams are rarely emergent. There is not like, I need an emergency pap smear. That is not a thing. And so, this does several things. It helps to orient the physician as to which specific patients they're going to focus this on, because if they start to feel like they have to do this whole procedure with every single patient, then they might start to get overwhelmed and feel like, I'm not going to do it with any patient. The way that I do it is already faster and better than this. But this, letting the physicians know, these are your patients who are the ones that are most at risk for negative outcomes. If you don't use these techniques, allows them to really focus these techniques on those patients who are most likely to have bad effects from not using the techniques. Then we go over setting up the room. So things like the temperature of the room and how that will actually affect the speculum exam. So if the room is too cold, what is the woman going to do? She is going to shiver. She is going to clench. If a woman is clenching her muscles, or the patient is clenching their muscles, that means that they might also be clenching their pelvic floor. And if they are clenching their pelvic floor, it makes it harder to insert a speculum. They should raise the head of the table to a semi-seated position. They should have different sizes of the specula available. A lot of times the medical assistant will just put out a speculum and just like a medium speculum, as though all vaginas are the same size. All vaginas do not require the same type of speculum. And so there should be a number that are available. They should have covers on the footrests and have a handheld mirror available. Now, my teaching point for this slide is that you want to teach in the order of the medical visit. So that is, as you saw before, we started with the patient still clothed and just doing the medical interview, and now we're setting up the room for the actual exam. So when you are teaching, if you go in the order that the medical visit happens, the physicians are more likely to retain that information about how to actually do something at each stage to make sure that it's more comfortable for the patient. Then we go over the anatomy of the specula. So I usually bring specula to these actual trainings. We go over the sizes, the plastic versus metal, the pros and cons of plastic versus metal, what the different shapes are for. You'll see here that some of them are longer and narrow, some of them are shorter and have this more bulbed end. That's because of some of the different shapes of vaginas. A lot of the physicians don't even know that. We talk about how the speculum opens and that there are ways of separating the bills. So you can separate the bills this way, you can separate the bills this way. Those are two different ways of separating the bills, and there are different ways of locking your speculum. I pass the specula around because what often happens with physicians is that they have like 1 hour-long training where they learn how to do a speculum exam, and I learned this, as I said, because I went through the training, and then the rest of the time is with patients. So if you are in with patients, you're not going to sit there and be like, oh my gosh, I don't really remember all the ways that this works. I'm just gonna go at it and try to figure it out while I'm in there. So giving them a speculum and letting them play around with it and really practice with it in the training when they're not in front of a patient is very important. And being able to describe all of these things, so doing your research on the actual things that you will be, the equipment that will be used in that situation. Now, my teaching point here, as I just said, is to have the hands-on practice, letting them practice not necessarily on an actual patient, but just with the equipment. The way that I have residents do this and physicians do this is to use their hand and to practice inserting, to practice opening, and to practice inserting and opening with some resistance using their hand so that they can feel what it's going to feel like when the speculum is actually inside of a person. Then we talk about setting up the patient. So as we said, we start off with those risk factors. They should explain the exam and then offer self-insertion. A lot of times people are like, what? I can't have a patient do that. Well, yes, you absolutely can. Patients should always be offered to insert something into their own vagina. And that is not something that was questioned a while ago. Back in the 70s, they were like, oh, is that having patients, do their own medical exam? And the answer to that, of course, is no. For practicing medicine is diagnosing or treating illnesses. Patients are allowed to put whatever they want into their own vaginas. And in fact, when I am treating vaginismus, and often I am treating vaginismus specifically so a patient can undergo speculum exams so that they can have a pregnancy, I actually have my patients buy their own specula on Amazon and practice inserting it so that they can get more comfortable with having a speculum inserted and knowing how to insert it themselves. They would correct any myths. They would make sure to let the patient know that the patient can stop the exam at any time. So this is the very important part of making sure that the patient knows that the patient is consenting to a medical procedure and that they can withdraw consent at any time. We talk about how to do undressing and how to explain undressing to the patient, and that the drape is optional. So that is, for a lot of patients, if you offer the drape and you say, oh, we're going to have you cover yourself, cover your lap after you've taken off your pants and your underwear so that you can have some modesty. I've heard physicians say that. We want you to cover that up so you can have some modesty. And then they come back in the room and they look under the drape. Well, that has just set up a situation in which their modesty is now not being respected. So that is not the best way of presenting that information. You can let them know that the drape is optional because they are going to be looking at the genitals as part of this exam anyway. Making sure how to set the footrest properly, and that the patient doesn't even need to do the footrest. That's just one of the ways that we've often taught it, and that they can offer a mirror. Then we go over dip tenting the sheet, which I will go over in the next slide. So this is what dip tenting the sheet is. If the patient's head is all the way down, you can see here that the patient is flat on their back. They can't see you and you can't see the patient. The drape is straight over the knees and they can't see anything that you're doing. But here you can see that this patient in the upper right-hand corner, her head is up. The sheet is flat against the abdomen and she is able to see me. This gives the patient more sense of control over the situation, over the exam that is happening, and it also allows her to see what you are doing as a physician. So if the patient can see you, she can know that you are not doing anything that is inappropriate. In the bottom right-hand corner, you'll see that this is the view from the patient. So the patient, because her head is up, she can see what the physician is doing and she can communicate with the physician anything that is not going well. This is going to really help a lot of those patients. So, go back here. So teaching point for this one is just to make sure that you are explaining. So here I went through a lot of details of just how to set up a room and how, very small things that they would do during a pelvic exam that could make a big difference in the patient's experience. And I tied each of the recommendations to the patient experience and how that would change the patient's experience and some of those risk factors that I mentioned at the beginning. So at the beginning, I mentioned powerlessness. Here, I stated how raising the back of the head here so that the patient can see you can decrease that sense of powerlessness and can make the patient feel like they are more in control of what's happening during the procedure. Here is where we review the anatomy of the pelvis And so this is one of the things that I was able to go over in a lot of detail, part of because of my history of treating sexual dysfunction. So I had a lot of knowledge about the pelvis in general, and how insertion of things into the vagina is often done in a way that is uncomfortable. So for this, we actually talk about the correct angles to insert a speculum, how you open the speculum in a way that's very different than how most of them learn how to open a speculum. Most of them see the speculum and they think that the way that you open it is by pressing the thumb plate down. But this, when it is inserted into a vagina, the top part of the vagina, the part that is that is closest to the stomach, is not very flexible, whereas the bottom part, the part that is closest to the butt, is very flexible. So instead of pressing this thumb plate, you actually can have a more comfortable experience if you squeeze this way. So you're squeezing backwards, where you're squeezing this part into the thumb plate rather than pressing down the thumb plate. This also means that you are using your strength to do the opening and with your forefingers rather than trying to force with your one thumb. This can make a big difference in terms of being able to find the cervix. And so for those of you who are not as familiar with the anatomy, the cervix is this part right at the end of the vagina and at the beginning of the uterus, which is part of what they are trying to see when they are doing a speculum exam. So with that, then we talk about actually performing the exam, how to ask for permission and then wait for a response. I often see people say, is it okay for me to start? And then they go ahead and insert the speculum without the person actually saying yes. That is not consent. Consent means that the person has said yes. And here I would often also say, you can even just have the patient, tell you when to start. You say, okay, tell me when to begin. That also will put the patient in control. They can insert their fingers and gauge the patient's response and discomfort first, so they can do the digital exam before they do the speculum exam. They can have the patient decide if the speculum is the right temperature. They can lubricate the speculum to make sure that it is more comfortable for the patient. And opening, oops, I went forward 2 things. Opening the labia from the posterior aspect with enough pressure. So this is very important because this also will make sure that the patient does not confuse what the exam is doing for being anything that is sexual. So another teaching point here, as we were saying, use your own knowledge of anatomy and pathophysiology if you are doing this teaching. If you don't know those things, you can absolutely look them up on any topic that you are interested in. So here we would go over asking permission or insert the speculum, waiting for a response, the speed at which you would insert the speculum, how to open the bills, as we already talked about. And one of the other things that we do go over here is language. You use language like bills. You don't say the blades. I hear a lot of times people call them blades. You call these things that she has her feet in, the footrests, and you talk about the examination table as a table and not a bed. These things all will make the patient feel more comfortable and make sure that they do not perceive anything as being sexualized. Another teaching point here is that we would emphasize which parts have evidence backing it. Otherwise, we would just give analogies. So for some of these things, we might say like this, we might say specifically, this study has found this, or this many women has found this. Other things, we might give analogies to other things that are within the context of medicine. So the analogies should pull in other things that are medicine related. So things like, you might say that, asking the patient to do this would be like asking a person with hypertension to do this other thing. So making sure that you're using any kind of medical analogies in your teaching. Then we offer specific techniques for those distressed patients. Some of these, like the Valsalva maneuver, a lot of them have actually heard about in other situations, but have not known that they could actually use it for a speculum exam. We, again, go over here how to use language to help the patient. So, you would say, for example, you allow your legs to fall out to the side. You do not say things like open your legs. Other things that could help these distressed patients would be diaphragmatic breathing, progressive muscle relaxation, guided imagery, color, breath work, diaphragmatic breathing, deep rhythmic breathing, breath counting, distracting, and centering. Now, most of these things here are not things that the physician is going to do. These are things that they would refer the patient to me to do. And so when we're teaching, we would talk about these first two things are the things that you can do. And if they don't work, this is when you would refer to me, and then I will help the patient through those things. And then often what I will do is I will see the patient for, sometimes for multiple sessions, sometimes just for a couple sessions where I teach the patient how to do these techniques. And then we will set up a session together where the patient comes in to get their speculum exam. I lead the patient through, for example, some of the guided imagery and pelvic floor relaxation while the physician is able to do the speculum exam. Then to finish off your teaching session, you want to make sure to always go over the things that are really the areas where they could create a lot more damage or that are really problematic. So most of the teaching is this is how you do it correctly. At the end, you want to make sure to say, like, these are the things that you want to make sure to avoid. So we have here a couple things. First of all, we would say, like, pushing the thighs apart no matter how subtle. And we would explain why that is problematic when you are doing a speculum exam and how that can, and that if a person who is getting a speculum exam starts to close their legs, how that should be addressed in a different way rather than just pushing their legs back open. A second thing that often comes up is that the physicians often will say, if a patient starts to clench up, they will say, just relax. Now, one of the things that we know is that in psychology is that people cannot have emotions on command. So if I were to say to any of you, feel anxious or get angry, you can't just start to feel that emotion because I have told you to feel that. A lot of our patients have experienced that when we say things like, oh, don't worry about this. If any of you have ever been told not to worry, you know that that does not actually decrease your worry. So if you tell a patient, relax or relax your pelvic floor, they are not going to be able to feel that emotion. They are also not going to be able to actually follow the directions that's being given. As a result of that, the patient is likely to get more and more stressed because they cannot follow the instructions that the person in power is giving to them. So here we give an alternative. What could you say instead? So when you in your head start to say just relax to a patient, how are you going to actually express that to a patient so that they know what it is that you want them to do? And what we would say here is that, first of all, there is no hurry to get this done, even if you are running behind, because this is the point at which when the patient starts to clench their pelvic floor muscles, that you could cause a lot of damage. And so this is the part where you should stop advancing the speculum. And what you are going to tell them instead is, I want you to bear down as though you are having a bowel movement. Now, bearing down like you're having a bowel movement, so hold your breath and bear down. That is actually explaining to the patient how to relax the pelvic floor rather than just giving them this kind of abstract, I want you to be more relaxed. The same will go for any other technique that you might be teaching to your physician. So a lot of times you'll see when somebody is doing a neurological exam, they'll be like, oh, relax your arms. Well, patients don't necessarily know how to relax. And so you would need to explain exactly what you want them to do with their arms so that it creates the muscle tension that you are looking for in that exam. The next point would be you would never force insertion against a contracted perineum. So if if the patient does start to clench up their pelvic floor, the solution is not to try to get it over faster. That is often people's instinct, is let's just go through this faster and try to get it done. But the reality is that that is actually what creates more and more of the problems. And so because it creates more problems, what you do in that situation is that you stop the exam until the person is able to relax their pelvic floor. And the last thing, which we discussed, some of the medical legal parts of it, because that also re-emphasizes to the physicians how important this part is that you cannot continue an exam when the patient says stop. And we make I don't mince words here at all, that when a patient says stop, they have withdrawn their consent from this procedure. And to continue to do the procedure after the patient has withdrawn consent has huge medical legal consequences. So this next part, which is a teaching point especially for physicians, is to create a pocket card. So this is a pocket card that me and Dr. Williams did create, and we now have it, of course, available electronically so that people can pull it up that way. But the way that a pocket card is often created is so that it can fit into the pocket of the white coat that many physicians wear. So it is an 8.5 by 11 sheet of paper printed in landscape mode so that it can be divided into these three and then fit. It can be folded into thirds and fit very easily into that pocket. By having this pocket card, it summarizes all of the things that you just went over, and it makes sure that the physicians have something to take away so that they can actually implement this in their practice. As many of you are probably aware, if somebody has just sat through a training, they're going to forget most of the things from that training. So in this pocket card, you will see here that there's just, a cover page, but then we go through each of the things that was covered in the training. So we have the screening and the actual wording of each of those screening questions that we went over. Like, has anyone ever touched you in a way that made you feel uncomfortable, or made you do something when you didn't, made you do something sexual when you didn't want to? So that wording is right here in the screening so that they can pull this out and ask it of the patient. If you have an electronic medical record, you can also create this whole thing as a template in the electronic medical record if you have smart phrases, so they can just keep looking back and making sure that they're going through each step. So for this, we have each of the main points for each part of the training that we went through. We also have some helpful resources, because we always remind the physician that when they are screening for sexual trauma, that if the patient says yes, it does not mean that they need to address that in that visit. It does not mean that it definitely does not mean that they should ask the patient what happened, because they should not. But what it does mean is that if the patient does say yes to that the patient should then ask the patient, is that something that is still affecting you? Will it affect the visit today? Would you like some resources? And then, or a referral to our behavioral health team to further discuss that if it's still impacting you. And so we do have some of those resources here. And then we have a lot of those tips that we went over, as well as the things that we would want them to avoid. Now, for those of you who are on this call today, I did want you to know that there is, if you are interested in patient-centered pelvic exams, Dr. Williams and I did actually publish this in Teaching and Learning in Medicine, so it is called A Guide to Performing Pelvic Speculum Exams, so you can actually look up a lot of this information. It did come out in 2013, so some of the information is outdated and some of it does need to be updated, but many of the things in there are still accurate. So if you are interested in that, or if you need to forward that to the physicians and nurse practitioners in your lives who perform pelvic exams to help them to do this a little bit better, please feel free to use that article. We have a special thanks to Dr. Bruce Ganeshan, who helps with some of these techniques, And I also have here some of the, a lot of the resources if you needed to look up any of those things or if you wanted more information. If you have other questions, please feel free to contact me. This is my email address, and I think that also was sent out on the invitation for this. But if not, the organizers of this event will be able to forward you my email address if you need it. So now I wanted to give some time for people to ask questions.
It looks like we have one question from our extern, Isha Kumar. So she said that a past patient of mine with endometriosis discussed her traumatic experiences and extreme pain during her pelvic exams. Have you done any trainings or lectures on the pelvic exam specific to women with endometriosis?
That is a great question. So I usually don't do the training specific to endometriosis, but we do talk, after we do this initial training, what we usually talk about with that part that talks about a lot of the different painful experiences. So endometriosis falls into the general category of dyspareunia. It does create pain during sexual contact. So once we do the training, we remind people that if the patient does actually have dyspareunia or if the patient does have this vaginismus, that is a patient that would be then, you would consult with me. So I am you could consult with me about what are the specific techniques that you are going to be using for this patient. And because a lot of times there's also going to be a referral to me, if I am teaching people who are within the same department, I am able to then say like, okay, this person is having this, they're having a hard time getting their speculum exams. I am going to meet with them and we are going to create together a method so that then we can do an actual evaluation. So I would do a full evaluation with that patient to find out more about their specific pain pattern. Not all people with that endometriosis are going to be triggered by the same types of things, and so we would find out what they have done before, what's created pain in them before, what has not created pain in them before, and we would come up with several different things. One, do they actually need a speculum exam? For endometriosis, sometimes you don't necessarily need a speculum exam. Sometimes you might need more of like, sometimes it's more like of a pelviscopy or something like that, which is a surgical technique. But sometimes it might be that the risks of having that pelvic exam outweigh the benefits of having it. The things that we are often looking for in a patient when they are getting a pelvic exam, if a person, so for example, I have some patients who are like, hey, I've had one sexual partner in my entire life. And my sexual partner also had one sexual partner, and that was me. That person is not at risk, not at high risk for human papillomavirus at all. The chance that person is going to have HPV and actually need a Pap smear is really, really low. And we could decide as a team that the risks of doing a Pap smear every 1 to 5 years actually outweighs the benefits of doing that Pap smear for that individual because their risk of actually getting cervical cancer is so, so low. But depending on the person's, so that would be thing number one. Thing number two is if they do have a reason that we do need to actually do the speculum exam, we would try to figure out ways of doing it that would be most helpful. Now, there are ways of doing a speculum exam under conscious sedation, which is a form of anesthesia, that does, if a person does have a history of trauma, and especially if it was a sexual trauma that was incapacitated. So an incapacitated sexual trauma is often when the person is incapacitated by drugs or alcohol. That can be very triggering in and of itself, and so we don't always want to recommend that, but it would depend on the patient's individual history. Now, I do see there's another question in the chat. It says, after a patient says, stop, how would you instruct physicians on taking out the speculum? Perfect, great question. More so in terms of removing it slowly and informing this to the patient who may be distressed and wants the speculum out quickly. So if the patient says stop, usually what I instruct physicians to do is say, is to say, okay, I'm stopping. What do you want me to do? Because sometimes when a patient says stop, what they mean is I want you to pause, not necessarily that I want you to take it out and start over. Sometimes they're just like, I just need a moment to catch my breath. And so the first thing when the patient says stop is say, what do you want me to do? And if they're like, get it out of me as soon as possible, you can remove it faster, but you're still going to remove it in a way that ensures that it is not completely closed when it reaches the introitus or the opening of the vagina, the vaginal opening. Because if it's all the way closed, you are at risk of actually pinching the vaginal walls. And so that could create pain, but you can actually remove the speculum fairly quickly. The insertion has to be pretty slow, but the removal can be faster as long as you don't close the bills completely. How have you worked with physicians? Oh wait, did I miss anything? Who have been less receptive to this training? This is a great question. So most of the physicians, once I do the training, there is a lot of buy-in. Even physicians that are like, I have done 1,000 pelvic exams. Part of the reason why I did this training for you is because the feedback that I often get from this training is that people say that some of the ways in which I teach and how I connect what each technique I'm saying is with the patient's experience, which they might not have experienced a lot of times they walk away, and I've had people who are like, you know what, I've done thousands of speculum exams, and I didn't think I was going to learn anything from this, and I even learned something from this. So usually there is a lot of buy-in once they have it. There has only been 1 or 2 times when I've had people who are less receptive. One was a physician who was just very convinced that speculum exams were painful and should be painful every single time. This was, of course, very, very concerning. So what I did in that situation was that I then partnered with other physicians who were doing a lot of the techniques that I did, and I had this physician to consult with them, and that those physicians were able to say, actually, 99.5% of my patients have pain-free speculum exams, and if you are and if you're experiencing pain, if your patients are experiencing pain, we're happy to help you make sure that doesn't happen. So basically, getting some other backup from other people who are more regularly doing this procedure. All right, I have another question, which is considering our trainee audience, what is the most important part of training that prepared you for your career? So one of the things that I think was most important for this specific career was my fellowship. And actually, I think if you're on the Division 38 listserv, I think there was actually just today a listing for this fellowship. I think they have an opening right now. So I did a fellowship in health psychology in the Consortium for Advanced Psychology Training in Michigan. So that was such an important part of my training because even though, I had great training in graduate school and in internship, it wasn't until I did my specialized fellowship in health psychology and primary care psychology that I actually learned not just like what I could teach physicians, but also to gain the confidence that I, as a psychologist, had a lot to offer for physicians. We are often in a society that really honors physicians a lot, but does not honor mental health professionals at the same rate. And being able to learn from my fellowship the specific skills that I needed to interact with physicians, but also the confidence to realize that I am also a doctor, that I am co-equal to physicians. We are both doctors in our field, and that I know just as much about my field as they know about their field. I just also happen to know some things about their field, and they happen to know some things about my field. But this was a way for me but that fellowship was really, really helpful in developing those specific skills. So I do highly recommend those types of fellowships if you are interested. And if you are interested in health psychology, since that is what this is on, I do know that the Society for Health Psychology's website, I believe they do have a list of health psych fellow training programs if that is something that you wanted to pursue. If not, the listserv is always, that Division 38 listserv is often posting those fellowships. Are there any other questions? Well, thank you very much for this opportunity. I really appreciate being able to give this talk to you, and I hope that you are able to learn a lot of things about pelvic exams and about teaching.
Thank you so much, Dr. Williams. That was very informative and very interesting.
Thank you.